tous. I call this meeting to order. Welcome, bienvenue à la réunion.
Welcome to meeting number 15 of the House of Commons Standing Committee on Health. We recognize that we're meeting on the unceded territory of the Algonquin Anishinaabe peoples.
Format pursuant to standing orders. I want to remind participants of the following points. Please wait until I recognize you by name before speaking. For those participating by video conference, please click on the microphone icon in front of you to activate your mic, and please mute your mic when you're not speaking. Also, at the bottom of your screen, you will see a little globe icon. If you press that, you can get English or French, whichever you choose, or floor, whichever you choose. A reminder that all comments should be addressed through the chair. Now, and when you wish to speak, if you're on Zoom, there's a little hand button on your computer screen. Please raise the hand. But we don't have any of our committee on Zoom today, so we can just do that. And the clerk and I will try and make sure that we see your hand and put you in order as you put it up. Now, sorry.
Madame la Présidente, j'aurais un appel au règlement, s'il vous plaît.
Point of order, Madam Chair. Could I read my point of order? I have a point of order. This study that we're starting today was on a motion adopted on September the 25th from my colleague from Montcalm, but on October the 1st, when I was replacing the Montcalm MP member, this was passed in order to reduce the functioning of testimony. It is agreed that committee meetings should be divided into blocks of 1 hour each, and that a maximum of 3 witnesses per hour should testify during the meetings. So I'd like to know, Madam Chair, because there was a change on the notice of meeting, was from 11 to 1 with 5 witnesses. So I'd like to find out. So this is a point of order because the motion that we have is not corresponding with the motion of October 21st, so that we can start the counter to 0, because this decision was made without consultation. So during the second hour, we'd like for the clock to start up again.
I think what I would like to explain is this. The chair tries to run the meeting so that it is on time, that it fills a time slot it's meant to be. We have been going over time on every single meeting we've had so far. I've had complaints from some members that they, knowing that the meeting is supposed to end at 1 o'clock, or in cases if there are IT problems, maybe a little later, but they all have appointments and they cannot keep it because the meeting goes on. It takes time when you have 2 separate hours to re-put people on. We have everybody on now. There's no need to stop at the middle of an hour. I think you're concerned about getting 6 minutes in the 2 hours. I think we could ask the committee if they would be happy to give you another 6-minute round without having to do this, because it takes up a lot of time and is very inefficient. Would the committee agree to allow the bloc to have another 6-minute time? Is that okay with you? Thank you very much, Madame LaRouche. All right, so pursuant to the motion on Tuesday, September the 23rd, 2025, the committee will begin the study of the antimicrobial resistance. I would like to welcome our witnesses. We have with us today Scott McNish, Director of Communications and Public Affairs of the ATMIS, the Canadian Society of Healthcare Systems Pharmacy, Dr. Rita Dami, I think she's online, Dr. Kevin Stinson, Program Manager from the Infection Prevention and Control Canada, the University of Western Ontario, Dr. Samir El-Sayed, and Winnipeg Regional Health Authority, Dr. Terry Wirtz. And so I'd like to explain the process here. Each of you has 5 minutes to present. I will give you a 1-minute shout out, and I mean shout out, and a 30-second shout out so that you can know how to wrap up. If you don't finish in time, I'm sure you'll get an opportunity during the question and answer session to say what it is or to expand on what you want to say. So we will begin with Scott McNish. For 5 minutes, please, Mr. McNish.
Yes, and thank you, Madam Chair, and thank you, committee members, for the opportunity. I'd like to begin by talking about the role of infection prevention and control plays when it comes to antimicrobial stewardship, and I'm sure there's people who are going to present today who know a lot more about infection prevention and control. I'm approaching this as a manufacturer, and I'm hoping that I'll be able to bring some new information to the table. So our premise is that helping people not get sick is probably one of the best tools we have when it comes to slowing microbial resistance. And our frontline healthcare workers try to do this a number of ways. I've worked in hospitals in infection and prevention and control, and I'm sure you all are aware there's campaigns across the country about washing your hands. You're also familiar with the role PPE plays in simultaneously protecting frontline healthcare workers and the patients that they care for. I'm going to be focusing today on single-use isolation gowns, which play an important part in our system's overall infection prevention and control strategy. So typically these gowns are made from man-made fabrics like polypropylene. Polypropylene is layered during manufacturing to create spun bond surfaces with a melt bone center, and then they're sold in bulk to companies who cut the gowns out of the material, weld the seams together using ultrasonics, fold, bag, and box them, and send them out for shipment. This is what my company does. We have a facility in Chatham, Ontario, 38,000 square feet, and we use robots to manufacture. So a little bit of science. The level of protection an isolation gown offers is determined by how it stands up to fluid penetration and testing, as decided on by the Association for the Advancement of Medical Instrumentation, or AAMI. AAMI tells us that we need to test both the gown's material and its seam strengths, or its seams, and how to conduct these tests, which are typically done by an accredited laboratory. How a gown performs is determined by several factors, including the quality of the polypropylene, the density of the material, and the integrity of the welded seams. So a level 1 gown offers the lowest level of protection, a level 4 gown the highest. Healthcare professionals are trained to know which level of gown they need to wear for effective protection, and this is where the rubber hits the road. Excuse me. Their decision is based on information the gown manufacturers have provided to the buyers at the institution in question. And I'm here to tell you today that that information is frequently untrue. So a series of facts. According to the National Research Council, our country goes through 8.7 million isolation gowns a month. Number 2, the vast majority of these gowns are made in Southeast Asia, mostly in China. They're imported into America by a handful of companies who then ship them to Canada, sell them to our healthcare institutions. These are the same companies who were on deck to provide Canada with emergency PPE when the pandemic hit in 2020, and we all know how that story ended. So fact number 3, although these importers have valid Health Canada medical device establishment licenses for their warehouses here, the factories making the gowns, many of which are in the Uyghur Autonomous Region of China in violation of Bill S-211, do not. Number 4, any company can run multiple tests for compliance with AAMI standards and cherry-pick their results. Nobody needs to know how many times your gowns fail before they finally pass. And number 5, once you've got a lab result, there's no follow-up. If a company changes its material supplier or its place of manufacture, nobody is watching, nobody's going to know. Last but not least, no one is even checking to see whether these labs are authentic. So during the pandemic, my company encountered multiple organizations, other companies, using falsified lab reports to sell their gowns to hospitals, to shared service organizations, and even to the federal government. So as a result, frontline healthcare workers are being given substandard gowns to wear, some of which are highly flammable, and Canada has over $100 million worth of isolation gowns in the National Emergency Strategic Stockpile right now, made by companies that provided false lab reports. Fortunately, these gowns were procured by the government, are unlikely to be used. The last of the Nest gowns, that were delivered in March 2022 with a 2-year shelf life, meaning they've long since expired and they have not been replaced. So what's the takeaway from all of this? I think if we're going to practice good antimicrobial stewardship, we need to start buying PPE that actually meets AAMI standards. It's a failure that lives at the intersection of our healthcare procurement policies and procedures, and I think it's having an effect not only on microbial resistance, but everybody in the country, from hospitals to the federal government.
I did not give you a 30-second warning, so you have 14 seconds left.
All
Sorry.
right. The solution is to buy PPE from manufacturing plants with MDEL licenses, ISO 9001 quality, tracking and traceability. I think that making these standards mandatory would advance your work on antimicrobial strategy or stewardship faster and with broader results than a lot of other initiatives you could take. Thank you.
Thank you very much. I now go to the next witness, Dr. Rita Dami, Canadian Society of Healthcare Systems Pharmacy. Dr. Dami, you have 5 minutes.
Thank you, Honorable Chair and members of the committee. I am the Chief Pharmacy Officer at CSHP and a clinical professor at the University of Waterloo. Regret that I can't be with you in person today, but I appreciate the opportunity to appear once again to speak about AMR. When I last presented on AMR, it was for the Science and Research Committee. I focused on evidence, I focused on research. But today I want to share with you a more personal day-to-day reality and the opportunities I believe we have to act on. I've been a pharmacist for over 20 years, with nearly half of that time spent as an antimicrobial stewardship infectious disease specialist. I can tell you with confidence that every day, pharmacists across this country confront the consequences of antimicrobial resistance. Patients who don't respond to first-line treatments, infections requiring more toxic or less effective options, longer hospital stays and preventable complications, and families who are devastated to learn that their loved ones have deteriorated from an infection that became life-threatening. AMR is not a theoretical risk, it's a present-day reality. The Pan-Canadian Action Plan on AMR offers a strong foundation, offers us pillars that we can action, but it needs some dedicated resources, timelines, and sustained federal leadership to meet the urgency of this threat. So firstly, we have an opportunity to strengthen national surveillance of resistant organisms and antimicrobial use. Canada already has a strong surveillance program through the Canadian Nosocomial Infection Surveillance Program, that's CNISP. CNISP offers both pathogen and antimicrobial use surveillance in both adult and pediatric inpatient populations. Work that I've been involved, the CLEAR registry further complements the CNISP work by monitoring real-world use of newer antimicrobial. Now, together, these databases offer a powerful and efficient national surveillance model. CNISP tells us how much antimicrobials are being used, and the CLEAR registry tells us why they are being used. So Canada should continue to support scaling these data platforms so AMR and AMU surveillance can be expanded outside of hospitals into long-term care and community care settings. Secondly, we have the opportunity to build sustainable antimicrobial stewardship programs. Accreditation Canada requires that antimicrobial stewardship and infection control are required organizational practices for all hospitals. However, we know the expertise, data access, and the staffing and infrastructure behind these programs varies widely across the different provinces. And we also know that hospital prescribing of antimicrobials is only one part of the picture. Provinces and territories need support to build sustainable, high-quality stewardship programs across the healthcare continuum. That includes long-term care, primary care, and also the outreach to rural and remote communities. Surveillance data informs stewardship programs and allows clinicians to detect and address the emerging risks sooner. Thirdly, we have an opportunity to improve access for antimicrobial therapies. Antimicrobial development has not kept pace with the need. We know that since 2010, 18 antibiotics have been introduced globally, but only 3 of them have had market access in Canada. The Public Health Agency of Canada has done a lot of work on push and pull incentives And that's formed a good foundation for improving access to the antimicrobial pipeline. But we now need to move from sort of that exploration phase of the push and pull incentives to implementation if we want timely and equitable access to next generation therapies. So in closing, the next steps are clear: strengthen surveillance, sustain stewardship, and secure access to effective treatments. As a pharmacist, I've seen firsthand what can happen when those systems fail and what is possible when they are supported. Canada has the infrastructure and the expertise. What we need now is sustained federal leadership and stable funding to turn those plans into action. Thank you again for the opportunity.
Thank you very much. Now I go to Dr. Kevin Stinson, who is Infection Prevention and Control Canada Program Manager.
Thank you, Madam Chair and members of the committee, for the opportunity to appear today. Merci aux membres de la comité pour l'opportunité à présenter.
Thank you to members of the committee to giving me the opportunity to present today.
I'm unable to as well attend in person. In October, I had the opportunity to appear before the Science and Research Committee, and I'm quite encouraged to see that this challenge of AMR is being picked up and looked at by so many different aspects of our government. AMR is, after all, a very complex and cross-sectoral threat, which truly does require a whole-of-government response. Now, my background is as a microbiologist and an infection control professional, and while I'm working in the acute care sector in Kitchener, Ontario, I'm here today really representing infection prevention and control professionals from across Canada and across the spectrum of healthcare on behalf of our professional association, IPAC Canada. AMR has been described as a silent pandemic, and what this really means is that a significant aspect of cases and transmission largely goes undetected. We already see significant socioeconomic and direct health impacts of AMR both in Canada and abroad. Now, contrary to typical pandemics or epidemics that we think of in especially recent memory, there's a bit of a unique challenge with AMR, as antimicrobial resistant organisms, or AROs, have this unique ability to transfer their resistance gene from one bacterium to another, including into the bacteria that occupy our human microbiome, the bacteria on our bodies. This creates a real challenge of persistent colonization, where someone can be persistently colonized and increasing their risk of downstream resistant infections, but also transmitting from one person to another. We see today upwards of 1 in 10 Canadians in acute care hospitals are colonized with at least one ARO, and this number increases significantly when we look at low and middle income countries abroad. AMR is, after all, a global threat which really does not know any borders, and effectively controlling and responding to this threat requires coordinated efforts along the lines of surveillance, infection prevention and control, or IPAC, as well as antimicrobial stewardship. Now, in healthcare settings, infection control professionals, or ICPs, form a backbone of the core personnel required and responsible for implementing these strategies. However, we see inconsistencies across Canada in how IPAC programs are implemented, as well as access to trained and certified ICPs in all healthcare settings. From a surveillance lens, Canada's surveillance programs broadly acts to give large-scale, generalized AMR trends, but it lacks the depth and the breadth to be able to actually map transmission, and it lacks the granularity to be able to take that data and apply it to influence practice at a local level. Now, infection control professionals rely on good, solid evidence and good, solid surveillance data to optimize our AMR's control and surveillance strategies within our facilities, both meeting the needs of our communities, but also balancing clinical operations and financial stewardship. Without this data, we're left trying to generalize or take generalized data and unable to apply it directly. And these disparities are especially prominent in rural settings or sectors outside of acute care. Now, to address these problems, we need to look at building our infection control capacities in the healthcare workforce through training and capacity development initiatives, such as what we see with the IPAC Hub program currently operating across the province of Ontario. When we look at longer-term strategies, Canada really needs to look at improving our overall AMR surveillance program. What we need is an integrated,
minute.
multi-sector approach with a specific focus on understanding transmission dynamics and using that to find control measures both in and out of a healthcare setting. We also must continue to look at how Canada can support broad public health initiatives such as backing vaccination campaigns, which are aimed at preventing infectious diseases, which indirectly does support antimicrobial stewardship efforts. So with that, I would again like to thank you all for the opportunity to present today. I will be submitting a written brief in follow-up to this session outlining these points in greater detail and certainly welcome your questions. Thank you very much. Merci.
Thank you, Dr. Stinson. I now go to Dr. El Sayed from the University of Western Ontario. Dr. El Sayed, you have 5 minutes. Thank you.
Good morning, Madam Chair and honorable members. Thank you very much for the invitation. It's an honor and a privilege to appear before this committee to answer your questions and to speak about antimicrobial resistance and its impact on the health of Canadians. My name is Dr. Samir El Sayed. I'm an infectious diseases physician and medical microbiologist at London Health Sciences Centre and a full professor at Western University. My educational credentials also include advanced degrees in public health and healthcare quality. I've been practicing as a clinician, educator, and researcher for over 25 years and have held several leadership positions throughout my professional career. In 2009, I was appointed chair of the Antimicrobial Medication Committee at London Health Sciences Centre and continued to serve in this capacity. Since 2013, I have served as the physician lead for the Antimicrobial Stewardship Program at London Health Sciences Centre and as the program's representative on the hospital's Quality and Patient Safety Committee. From 2017 to 2020, I served as the elected chair in infectious diseases at the Ontario Medical Association. And in 2018, I was appointed director of the Adult Infectious Diseases Residency Training Program at Western University and continue to provide educational oversight of this program. So the topic under discussion today is near and dear to me and one that all Canadians should take to heart, including policymakers, researchers, healthcare administrators, regulated health professionals, and members of the general public. According to the World Health Organization, antimicrobial resistance, commonly referred to as AMR, is currently one of the top 10 global public health threats to humanity. In 2021, AMR was directly responsible for over 1.1 million deaths and contributed indirectly to an additional 4.7 million deaths. Scientific modeling studies predict that by the year 2050, these numbers will double, and annual excess healthcare costs due to AMR will exceed $2 trillion US without appropriate action by governments, the healthcare community at large, and other global stakeholders. Antimicrobial resistance affects all geographical regions, income levels, and age groups. It compromises the ability of the healthcare community to provide safe and effective treatments to individuals suffering from infectious diseases. AMR is often referred to as a silent pandemic because it typically spreads unnoticed. AMR is linked to several human behaviors. Misuse of antimicrobials involves selecting the wrong antimicrobial agent, dosage, or duration of treatment due to diagnostic uncertainty, lack of knowledge, or patient demands. Overuse relates to antimicrobial use that is considered unnecessary, for instance, treating a viral infection with these medications. In some countries, there is unregulated access and minimal oversight of antimicrobial use in humans, as well as in animal husbandry. In Canada and many other high-income countries, approximately 50% of antimicrobial prescriptions in community settings are considered inappropriate, in other words, misuse or overuse. These numbers are slightly lower in hospital settings at around 30%. In 2013, antimicrobial stewardship, or AMS practices, became an accreditation requirement for all Canadian acute healthcare facilities. In contrast, AMS became a mandatory practice for acute care hospitals and long-term care facilities in the United States in 2017. Currently, long-term care homes in Canada are exempt from this requirement, even though they bear a large burden of inappropriate antimicrobial use. There is a natural cycle of antimicrobial use and its consequences that involves humans, animals, and the environment. Agricultural use of medically important antimicrobials in Canada and the US is more than twice that in humans. On a per capita basis, use of antimicrobials in Canadian livestock exceeds that of the US and most European countries. Antimicrobial resistant organisms can spread from animals to humans through food, contamination of wastewater and crops, and even via transmission of animal wastes to birds, ticks, flies, and rodents that may come into contact with humans. Human waste from hospital sewage systems contain AMR organisms due to heavy antimicrobial use, which eventually enters our water supply, the natural environment, and food-producing animals, repeating this never-ending cycle. Approximately 75% of all infections caused by AMR pathogens are acquired in hospital settings, while the remaining 25% occur through environmental exposure, international travel, and direct contact with animals. Fortunately, several concrete steps have been taken by the Government of Canada and provincial territorial governments to mitigate the burden of AMR by supporting initiatives that promote the judicious use of antimicrobials. In this regard, the Pan-Canadian Action Plan on Antimicrobial Resistance was launched in 2023 and is built on 5 pillars: research and innovation, surveillance, leadership, infection prevention and control, and antimicrobial stewardship. However, there are still gaps that need to be addressed, including expedited regulatory approval for new antimicrobials, increased restrictions
to wrap up,
on the
please. And you can elaborate on it during the question and answer period. I'm sorry. I now go to Winnipeg Regional Health Authority, Dr. Terry Wurz, infectious diseases physician. Dr. Wurz, you have 5 minutes.
Madam Chair, Vice Chairs, honorable members of the committee, thank you for the invitation to speak today. My name is Dr. Terry Wurz, and I'm a practicing infectious disease physician from Winnipeg. Antibiotics are foundational to modern medicine. They're not just treatments for infections, they're enablers of routine and life-saving care. Every day in Canada, antibiotics make it possible to safely perform surgical procedures such as joint replacements and C-sections, chemotherapy and immunosuppressive therapy for cancer and autoimmune diseases, organ transplantation, intensive care interventions, and safe care during premature labor or neonatal complications. Without effective antibiotics, these cornerstones of modern healthcare become unsafe or impossible. But the effectiveness of antibiotics is not guaranteed. We are already seeing them diminish. One way to think about antibiotics is as a finite resource. I often describe them as a trust fund. Every time we prescribe one, we withdraw a little from that fund. When antibiotics are used appropriately, they save lives. When they are overused, misused, or used in situations where they provide no benefit, antibiotic resistance accelerates. If we don't reinvest in this resource through careful stewardship and access to new drugs, we risk stealing from the future to treat patients today. The consequence of that erosion is visible on the front lines. In Manitoba and across Canada, we're seeing infections that no longer respond to first-line antibiotics, more frequent use of toxic or costly last-line drugs, and sharply rising rates of resistant infections in both hospitals and in the community. Increasingly, we're encountering cases where no antibiotics work at all. These infections are caused by totally drug-resistant organisms, bacteria resistant to every available antibiotic in Canada. When that happens, we may be left with only one option: source control, meaning the physical removal of infected tissue. In the most severe cases, that could mean amputation of an infected limb. These are devastating outcomes for our patients and families, and they represent the direction our healthcare system is headed if we don't act now. We know what interventions reduce resistance and protect patients. The most effective is antimicrobial stewardship, the coordinated effort to ensure the right antibiotic is used only when necessary at the correct dose and duration. Stewardship programs save lives, reduce adverse drug events, shorten hospital stays, and decrease the development of resistance. There are also cost savings for the healthcare system. Yet, despite the evidence, stewardship programs across Canada are chronically underfunded. In my own province in Manitoba, including in our largest tertiary care hospitals, there is no dedicated stable funding for antimicrobial stewardship programs. This means that programs operate intermittently, rely on voluntary effort, or disappear when the temporary funding ends. We cannot protect antibiotics without protecting the programs that ensure their use safely and appropriately. Another challenge is access to new antimicrobials. Canada lags behind peer nations in bringing new antibiotics to market. Only a small fraction of newly developed antibiotics ever reach Canadian clinicians, and when they do, the path to reimbursement and formulary access is often delayed by years. This leaves clinicians caring for patients with highly resistant infections with very few options. The federal government already has a roadmap, the Pan-Canadian Action Plan on AMR. It was released in 2023, and it outlines the right priorities: stewardship, research, innovation, and coordinated leadership across federal, provincial, and territorial partners. What it does not yet include is implementation funding, timelines, or mechanisms to secure stewardship programs exist wherever antibiotics are prescribed. To make meaningful progress, I would highlight 3 actionable federal priorities. 1, fund and standardize antimicrobial stewardship programs in all healthcare settings: acute care, long-term care, and community practice. Stewardship is one of the most cost-effective interventions we have. 2, support rapid access to new and effective antimicrobials through streamlined regulatory pathways and incentives. 3, enable national coordination of antimicrobial resistance policy and implementation. Antibiotics made modern medicine possible. If we protect them, Canadians will continue to benefit for generations. If we fail to protect them, we will see more preventable deaths, more avoidable amputations, more treatment failures, and rising healthcare costs. Merci. Je serai heureux de répondre.
Thank you. I'll be pleased to answer your questions.
Worse. I now go to the question and answer segment. These segments, the first one is a 6-minute segment, and it means that the 6 minutes is for the question and the answer. So everybody, please be as concise as you can so we can get as many answers as we can get. So I begin with the Conservatives. Dan Major, 6 minutes, please.
Thank you, Chair, and thank you for the witnesses for coming out here today. Mr. Megnish, you mentioned that Canada's National Strategic Stockpile contains expired medical gowns. What evidence supports this?
Thank you. I guess we can go back to the pandemic in 2022. So in 2022, I was part of the last team, I was part of a team that delivered the last isolation gowns to the National Emergency Stockpile. That was in March. They had a 2-year shelf life, and so those gowns all expired in 2024. I can tell you that as a company interested in this market, we watch the Canada Buy site very closely. That's where Canada, the Government of Canada, tenders all of its procurement. So we know that in September 2022, there was an RFI on Canada Buy looking for ways to dispose of the stockpile, but there was never an RFP issued or request for proposals ever issued. We also know from Canada Buys that the government has yet to not only tender that RFP or RFSO, but they have renewed contracts with the same companies that let us down during the pandemic. They've extended those contracts. The last one as recently as August of this year. And so while there may be product in the pandemic or in the National Emergency Strategic Stockpile, there are definitely no gowns. And what material we do have, we also know is being sold through gcsurplus.ca, which is where the Government of Canada disposes of surplus product. They created a new category on that website this year for PPE, and they're selling masks, gloves, other products there for pennies on the dollar.
Do you believe it's appropriate or even safe for Canada to rely on expired protective gowns in the event of a health emergency?
Well, no, it's absolutely not safe. Those gowns have shelf lives for a reason. Ostensibly, it's because they will perform at their advertised safety levels for that period of time, after which the amount of protection they offer drops. But of course, we also know that there's a significant number of gowns that were sold to the Canadian government with false lab reports, so we don't even really know how those gowns could perform in the first place. It's a big mystery. We do know many of them are flammable.
Megnish, what proportion of the protective equipment in Canada's national strategic stockpile currently comes from China?
Right now, if Canada were to procure, again, through one of those companies that was on the 2020 request for RFSO, request for standing offer, all of those companies import from China. So if the government of Canada deemed it necessary to procure gowns, which it ought to, because they have none, right now they would all come from China.
100%.
100%.
Wow. Does this reliance on PPE from China create a health and safety risk?
I believe it does when you take a look at the quality of the product that is being imported. It's, as I said, often inferior. It's not made in an MDEL facility. We know it's much of it is highly flammable. We know the labs are suspect. It really comes down to a price point. And also what the system is used to. The system is used to procuring through these large medical device suppliers, and it's incredibly price sensitive. As everybody knows around the table, you don't want to lay off nurses so that you can buy better gowns. If everybody's happy with the gowns, the thing is that they ought not to be.
Megnish, the media reported that Health Canada lost more than $20 million in health supplies from Canada's National Emergency Stockpile. Unfortunately, the government won't provide the specific details on this, citing national security. I think Canadians deserve to know why the government lost $20 million. Is this a national security issue, or is this a bigger issue that the government's trying to hide?
I can't speak to the issue of the vaccines because we don't make vaccines. However, we do make PPE. I don't know how it could be national security if it's advertised on Canada Buys. And so if the offers to procure are made in a public way, in a public forum, Canada Buys,
1 minute,
then ostensibly it's not national security, it's of the public's interest. I think that's why there is so much transparency there and why that website was created.
Megnish, based on your experience, what is the biggest concern with how the federal government is managing Canada's national strategic stockpile today?
I believe it isn't. I believe
30
they've
seconds.
essentially allowed it to expire. What they have, they're selling off at pennies on the dollar. They've renewed contracts with Metro Logistics, who's their warehousing company, to continue to warehouse expired product. $34 million a year. I think as a taxpayer, I take umbrage with that. This is the second year that this has happened, so $68 million to store expired PPE.
Thank you, Ms. Megnish. Thank you, Chair.
Thank you very much. I now go to the Liberals, Helena Jasek. Ms. Jasek, you have 6 minutes.
Thank you, Madam Chair. And I'd like to start with Dr. El Sayed. You were telling us your opinion of the 2023 Pan-Canadian Action Plan on Antimicrobial Resistance. And you, I think, endorsed 5 pillars, but you were going to explain to us what you felt were some gaps. So perhaps you could take this time to elaborate a little bit on what you see as gaps in the plan.
Yes, thank you. Madam Chair, the way I would answer that is, so the gaps that exist right now are the expedited regulatory approval for new antimicrobials. This is urgently needed at the federal level. So the delay between the availability of newer antimicrobial agents in the US and Europe and their introduction to the Canadian market often exceeds 7 years if they become available at all. Many clinicians in my field rely on the Health Canada Special Access Program to secure access to some of these newer antibiotics. However, the process isn't feasible for managing life-threatening infections. For some medications, it might be next-day delivery, but for others, it might be 3 weeks. There are also shipping costs involved. So for some of the drugs, we have to sign a contract with a manufacturer, and that contract might involve shipping costs that are in the thousands. And again, a delay of 3 weeks would be unacceptable in this type of setting for a life-threatening infection. Only 1 of 6, so one of the other panelists commented that since 2010, 3 of think 15 antimicrobials have been approved by Health Canada. In the last 10 years, only one of 6 that are designed specifically to target the critical priority pathogens according to the World Health Organization have been approved by Health Canada. There was one that was just approved in May or June of this year. But that's just one. There's like 5 or 6 other ones that we need access to, and we're going through the special access program. I don't think it's a problem with the special access process. It's just the actual delay. The other thing that needs to be done is there needs to be an online portal for the SAP program. Right now, we deal with phone calls, faxes, paper. It's very manually labor intensive, and I think that process needs to be improved so that we can speed up the process and make it more transparent. The other thing, well, there's 3 other things. The other thing that I wanted to highlight is the increased use of antimicrobials in domestic agricultural practices. Antibiotics are used as growth promoting products, and the use of antibiotics in animals obviously carries itself through to the food chain and then to humans and then to the environment. And so there should be some limits to the use of antibiotics in animal husbandry. As other panelists have mentioned, antimicrobial stewardship programs should be mandatory. Dr. Dami commented that even though it's mandatory for acute care facilities, there's lots of variability. Some places I know don't really have a good antimicrobial stewardship program, even though they're supposed to have one. As I have in my speaker's notes, but ran out of time, the antimicrobial stewardship requirements in the US are different than in Canada. In the US, all long-term care facilities require the implementation of an antimicrobial stewardship program. In Canada, we don't have that. This is very, very critical because elderly people in nursing homes bear a large burden of antimicrobial resistance. And so practices that can help mitigate unnecessary use of antibiotics are essential in that setting. There needs to be increased funding for hospital infection control and antimicrobial stewardship programs. That's kind of related to what I already said. So those are the 4 main points: expedited regulatory approval of newer antimicrobials, increased restrictions in domestic agricultural practices, mandatory antimicrobial stewardship programs, going beyond the acute care facility. I also agree that they should be implemented in the community, as I believe Dr. Stinson mentioned, or one of the other panelists mentioned, and then increased funding for existing hospital infection control programs and antimicrobial stewardship programs. 75% of the burden of antimicrobial resistant infections occurs in hospitals. The other 25% occurs in the community. So really a focus on hospitals should be a priority by the government. So I appreciate the questions, and I hope the answers will stimulate further discussion. So.
Thank you so much. My microphone didn't go on. That was very, very helpful. Dr. Dami, you made the comment related to the fact that there were only 3 of these newer antimicrobials available in Canada, even though worldwide there were some 18 or thereabouts available. Why is this? Perhaps what we've heard from some at the Science and Research Committee, some pharmaceutical companies are loath to even apply for use in Canada because the market is small and there isn't perhaps not the financial incentive to invest in the Canadian need in healthcare. So are you aware of what has happened in terms of access to these new antimicrobials in Canada?
Yeah, so what we do hear from our pharmaceutical industry colleagues is, unlike other drugs, antimicrobials are often prescribed for shorter or time-limited courses of treatment. We also know that while stewardship programs improve and optimize the use of antimicrobials, they can also have sort of that detrimental effect on limiting the growth potential of antimicrobials. And so
to wrap up, please, Dr. Dami. We're well over time on this round.
Sure.
And you can elaborate in another when someone else asks you a question. Thank you very much. I'm sorry about that. I now go to Ms. LaRouche from the Bloc. 6 minutes, please.
Thank you very much, Madam Chair. So quickly, we are at the Health Committee. I'd like to remind you that yesterday was the World AIDS Day, and so we have a lot of progress to be made. So I think it's appropriate to remind everyone of this important day at the Health Committee. Now, my question, I'll start with Dr. Magnish. You, in your preliminary statement, and my Conservative colleague alluded to this with regards to the supply chain. And in your statement, you said it was important to not obtain supply where people have. You said there was the Uyghur region where there's forced labor, and that this has an impact on the quality of PPE. On October 21st, we tabled a project to end what we call funding the modern slave industry. So in Canada, we want to. We understand that not everything is produced in different conditions, and it's important to have a bill such as that one in order to reduce the purchase of products, especially supply from countries where. Do you think it could have an impact to have this type of bill being tabled in the House?
Thank you. I should point out, you gave me a raise. I'm not actually a doctor, but thank you. So, in terms of protecting or the importance of this issue, I believe that we actually have legislation right now in Canada, Bill S-211. I'm not sure what if there's something new in the works, or the government or your party is introducing something, but absolutely important. If you look at the issue here. Man-made textiles coming out of the Uyghur Autonomous Region is one of their leading products. So it is one of the top things they make. And we're talking about a population of people who are, most governments around the world have agreed that they're living in forced labor camps to make dangerous products. So this is all in violation of Bill S-211 already. The problem with Bill S-211 is that nobody's enforcing it. Companies have to attest to the steps they've taken to purge forced labor from their supply chains every year, and they file that with the Minister of Public Safety, I believe. Companies are doing this, but it's essentially a checklist where they just check a box and say, no, we have no forced labor. There's some small steps they claim to take around training of their employees, but I can tell you, if you open up a catalog from one of Canada's leading healthcare suppliers and pick a product, which is literally what I did. It was the first product I picked, and then ran it through a database, an open source database run by human rights groups. You will find forced labor. You'll find products being made with forced labor. The government has renewed contracts with some of these companies. Certainly our healthcare institutions are too. Every single hospital in Canada, I guarantee you will find products that have been made with forced labor. So anything we can do to address this as Canadians, I think is important. It takes a step away from antimicrobial stewardship, but quality products can only help us in that regard as well. So I think it starts, though, with actual enforcement. Somebody needs to investigate these companies and lay fines, like the Act gives somebody the power to do.
Merci beaucoup, Monsieur Magnish.
Thank you very much, Mr. Magnish. And sorry for the promotion. So that's okay. And that's the criticism about S-211, is that it wasn't strong enough, and that is why the Bloc has tabled a bill that is more stringent. So now, Dr. El-Sayed, you quickly went over your conclusion, and you had to make it shorter because your time was over. Did you have anything else to add?
Thank you very much for the question, Madam Chair. I'd be happy to answer that. The other thing I wanted to mention was the lack of access to some of these newer antimicrobials is not just about mortality. I mean, mortality obviously is a big thing, something we think about. We have seen an increased number of deaths in our hospital, especially during the COVID-19 pandemic. We had multi-drug resistant organisms that we needed to go through the special access program. And during that time, it was very, very challenging. We didn't have the drugs on hand. But it's not just about mortality. There's also increased pressure in the hospital system in terms of the census of hospitals.
42 seconds.
So for instance, if we don't have access to one of these first-line antibiotics through the special access program, we have to use a second-line agent, which not only doesn't work as well usually, but also has more toxicity. These patients end up staying in hospital for a longer period of time. And there's also some disalignment with the clinical practice guidelines and the drugs that we have access to. So that needs to be looked at, both from the federal side, but especially on the provincial side, where we want to send patients home on an antibiotic, and there's no coverage there. I'm happy to address other questions, but just because of the time, I'll just conclude there. Thank you very much.
I now go to the second round. And I begin with Mr. Epp for the Conservatives. 5 minutes, please, Mr. Epp.
Thank you, Madam Chair, and thank you to all the witnesses for appearing today. I'm going to focus my questions with Mr. McNish. In your testimony, you referenced fact number 2. And I'll quote you, "We all know how that story ended," referencing the fact that we are dependent upon China for our PPE. Can you elaborate a bit more exactly what you mean by how that story ended?
Okay. And thank you. So I guess that story started in 2020. The federal government had introduced or had issued an RFSO, or a request for standing offer, to companies to supply the National Emergency Strategic Stockpile. Nothing wrong with that RFSO. They awarded it to several different companies, the same companies that supply the hospitals, same companies that you're probably all familiar with. The problem is that all these companies source their material or their products from overseas, mostly China, but Southeast Asia. And when the pandemic hit, they could not supply. And so I'm sure everybody in this room can remember the Prime Minister at the time asking companies in Canada like ours to pivot their focus and manufacture personal protective equipment. The nurses were wearing scarves wrapped around their faces. So this is how that story ended. The pandemic finally subsided. Canadian companies like ours had stepped up and were supplying the National Emergency Stockpile. Life got back to normal, and everybody started buying product from China again. Hundreds of millions of dollars were spent standing up Canadian industry on this front. It's an industry that's probably worth about $1 billion a year. We gave it all back to China. And let me just add one last thing. And we're still doing it. As late as August of this year, we renewed one of the contracts with one of those same companies, extended it out for another 9 months. And this is strategically disastrous because we know exactly what happens when we put all our eggs in one basket.
Mr. McNish, I have toured your plant. I have seen the 20 robots. They're sitting idle right now. And so is this an issue of cost? Is that why the industry has gone back? This is unfathomable. We have an entire country trying to reshore right now, and yet we are supplying, or we are sourcing from China with, as Madame LaRouche alluded to, potentially with the forced labor as well. So what's going on here?
It's cost, definitely. I mean, our hospitals are all struggle with budgets. They look for the best price they can get. Asia is able not only to provide lower costs because of lower human labor costs, but they're also able to manipulate the market because they're state-run. So if they want it to be cheaper, they can just make it cheaper. As a result, it makes it very difficult for Canadian companies to compete. Our competitive advantage, as I said, is that we make our gowns with robots equipped with lasers and ultrasonics.
But I do want to get more. That's fine if we're comparing apples and apples. Mm-hmm. But my understanding is we're not comparing apples to apples when it comes to quality. You mentioned some of these gowns are flammable. Can you prove that?
Yes. Actually, in anticipation, I brought a video which I can share with the committee at your leisure. It's on a memory stick that I can leave with somebody. But we did a side-by-side test of a hospital gown pulled from a local hospital in southwestern Ontario and one of our gowns, and set them on fire to see what would happen. There is no shortage of evidence. All you need to do is you could go buy one today. They're all publicly available as well, and just see how they perform. We've tested our competitors' gowns, like our Chinese competitors' gowns. They're definitely inferior, but we can actually beat them, or at least meet them on price, because of the competitive advantages that we have. And the second part of this then is that it comes down to preferences. So doctors might just like a particular brand. They've already gone through the process of vetting it. They're comfortable with it. They just keep buying it.
What's happening there right now, our government is going for a cheaper route as opposed to a safe route. They're going to a foreign supplier as opposed to a domestic supplier when we have the capacity right here.
That would be a correct assessment.
Would,
yes.
would it also be an accurate
30
statement
seconds?
that right now our NES, our National Emergency Strategic Stockpile, is in worse shape now than it was going into the pandemic? You talked about expired goods where polypropylene degrades over time.
Yes.
And those were the quality of those very same gowns is suspect, basis your testimony.
Yes, it is. We are in worse shape today than we were at the beginning of the pandemic in terms of preparedness.
Thank you, Mr. McNish.
Thank you very much, Mr. Epp. I now go to the Liberals. Ms. Sidhu, 5 minutes, please.
Thank you, Madam Chair. Thank you, all the witnesses, for coming here and your very informative testimony. My question is to Dr. Samir Al-Sayed. Dr. Samir, you talked about the lines of antimicrobial medications. How can strengthen federal stewardship initiatives such as national prescribing guidelines support physicians in reducing inappropriate antimicrobial usage? I have two aspects. One is like how to reducing, and the second aspect is when in hospitals the guidelines. When I just want to share a story, just last month in Brampton, one day a kid lost his mother because of no antibiotic, because of sepsis. So this is something, my question is to you, how could federal provincial collaboration improve equitable access to rapid testing and new antimicro, you told, like we need to access on that?
Thank you. Madam Chair, I'm happy to answer the question from the honourable member. We do have national guidelines for treating various infectious diseases, but we also rely on guidelines published in other countries, especially the United States and also in the UK. Now, they have different healthcare systems, different kind of funding programs. Some of the medications that are newly available in these countries are very, very expensive, and that's obviously one of the biggest barriers. We also publish and develop our own local clinical practice guidelines for how to treat different infectious diseases. We actually have a web page in our hospital that talks about how to treat bloodstream infections, urine infections, etc. Now, antimicrobial stewardship programs, which I'm actively involved in at my hospital as the physician lead, we are advisory. So we are an advisory program. So what that means is that we can educate and develop clinical practice guidelines, but we cannot force physicians or twist their arm, if you want to put it that way, in terms of how they can treat an infectious disease. We do have control of we do have influence on the hospital formulary, and that is what antibiotics do we have available in our hospital and who's allowed to prescribe them. So for these newer antibiotics, for the AMR pathogens, these would have to be gatekept, and there would need to be a gatekeeping function in the hospital so that they're prescribed appropriately. Now, I'm sorry to hear about that story about the child who died. I may have read about this story already because I do look and kind of read these cases in the news, so that doesn't happen again and kind of reflect on it. But I don't know how that occurred, whether there was a delay in initiation of therapy, whether it had to do with a drug-resistant organism. There is a disconnect between the federal and the provincial territorial kind of health programs in terms of antibiotics. So, for instance, we do have Health Canada approved antibiotics that we use in hospitals, but they're not covered by the provincial formulary. We have to go through, for instance, in Ontario, we have to go through the Exceptional Access Program. I've had requests denied very frequently, even for something that's clearly recommended by clinical practice guidelines. And I do believe that there are some outdated guidelines as well that the Ministry of Health in Ontario is using. I know this is not a provincial forum here, but I can tell you that there is a little bit of a disconnect. Now, Health Canada generally will not approve a medication for outpatient use if it's not approved by Health Canada.
1 minute.
So there's that issue. But clinical practice guidelines exist for many different infections. There's differences of opinion. For instance, treating eye infections, there's a difference of opinion between the Infectious Diseases Society of America and the American Ophthalmological Association in terms of how to treat. So that kind of may get in the way for certain things, but in general, we do have good clinical practice guidelines. We know how to treat these infections with first-line therapies. And really, the problem is having Health Canada approval. That process is delayed much more than the process in the European Union and the US, for instance. I think that's one thing there. But so I hope I answered your question well, and I'm happy to answer any other questions later on. Thank you very much for the opportunity.
Thank you.
Thank you.
Thank you, Ms. Sadu. I hate to sound crass, but I just wanted to say that, to remind everyone in the room that the food is for MPs first and foremost. Thank you very much. I mean, you can have some, but MPs should have the first dibs. Thank you very much. So we go now to Madame Larouche for 6 minutes. Madame Larouche.
Thank you. Thank you, Madam Chair. I'm going to continue with Dr. El-Sayed in your preliminary remarks. You spoke about the agricultural sector, and you talked about the use in the U.S. and Europe, antibiotic use in the agricultural sector, that it was different. So when we talk about the risks of products that are imported here, how is this important? What are the risks?
Thank you very much for that question. Madam Chair, I'm happy to answer the honorable member's question. That is a very, very good question. I wasn't expecting to get that question today, but I'm happy to answer it. Certainly, let's look at it from an individual perspective. If you are residing in Canada and you travel to a country where there's a high burden of antimicrobial resistance, and let's say you're there for a while or you get hospitalized, you will likely be colonized, meaning your normal bacterial composition in your skin or in your intestines will likely have some of those antibiotic-resistant bacteria. So you're going to take it back with you, and you're not going to be able to get rid of it probably for about half a year. If you get medical care in another country, there's a higher risk of getting an infection with an antimicrobial-resistant organism. I was the first physician in southwestern Ontario to see an antibiotic-resistant infection from a certain strain that came overseas in East Asia. And there were no treatments available at the time, but fortunately it was a urine infection. We decided just to kind of watch. It wasn't something in the bloodstream. The same thing would go with agricultural products that are imported into Canada. And I don't think we really know what's going on in that regard. We do have data from the US and from Europe, but also as well from China, where there's a heavy use of antimicrobials in their agricultural practices. And I don't know about specific countries. In Canada, the biggest use of antibiotics is in beef, livestock. That accounts for the higher proportion than in other animals. But I would say that importing, especially meat from this, and this is where the antibiotic-resistant issue would be of most concern, would be from meat products. Now, fortunately, we have a great dairy and beef industry in Canada, and hopefully most of what we get or what we use is from domestic sources. And I know that we get sources from the U.S. But certainly that's a good question. I don't think it's an issue so much with plant-based products. There's not a lot of antibiotics used in kind of crops, although there is. That's a minor component. It's more for meats. But I'm not an expert in that area. I did actually give a talk recently during Antimicrobial Awareness Week, which was held during the 3rd week of November. It's celebrated across the world. And I actually had a few PowerPoint slides showing how antibiotics are being used in our domestic cattle and other food-producing animal industry. And I kind of researched what was going on in other countries, but I don't have a lot of information because that's not my area of interest. But it's a very good question, and I believe that that is a concern. If we're importing meats, then we need to kind of look at that. That's also, a health security issue, I guess, if you want to put it that way. So, and that's all I have to say. I appreciate the question and happy to answer any more later on.
Merci beaucoup.
Thank you very much. So the Canadian processors, in Shefford, there is an office, and that's what they want. They want testing, and they probably see that the antibiotic levels do have a consequence. Dr. Denny, recently, with regards to pharmacists, I know that you have an important role to play in hospitals. More specifically, what role do you play when you observe there is inappropriate prescribing? This has been raised by many different people today.
Yes, thank you for that question. So as a pharmacist, we are the experts in drug therapy. Many pharmacists who specifically practice in the infectious diseases antimicrobial stewardship space have done extra specialization, certifications, and training to really get a good understanding of how antimicrobials are prescribed. And again, those sort of bigger picture impacts. As a pharmacist, if we observe or come across antimicrobials that are not guideline concordant, the first sort of step is to have a conversation with a prescriber, whether that's, a physician, nurse practitioner, or a colleague pharmacist. A lot of pharmacists across the country now can prescribe antimicrobials for minor ailments. And so really first step is to get a lay of the land of what's happening with the patient, assess the situation, and understand if there's an opportunity to optimize the therapies that are prescribed. There is actually a study out of Nova Scotia that compares antimicrobial prescribing amongst different healthcare professionals. And interestingly, pharmacists tend to be the healthcare professionals that are the most likely to prescribe within guidelines and maintain sort of guideline concordance.
Okay, so sorry. I'm going to the next questioner is Mr. Strauss for 5 minutes, please, for the Conservatives.
Thank you, Chair. Thank you, everyone, for being here. It's lovely to see Southwestern Ontario so well represented, Kitchener-Waterloo in particular. And it's also lovely to see Dr. Samir El-Sayed, who was my professor at Western some 15 years ago. And so, Dr. El-Sayed, I won't ask you to answer this question, but when you were talking about the special access program not giving you access, and you outlined your CV, and I know you to be a tremendous clinician and expert in the field. So the idea of the special access program not giving you access to a medication that you think is necessary and life-saving in a reasonable amount of time, I confess to just be feeling enraged when you told that story, because if Dr. El-Sayed thinks it's necessary, then it's necessary. So maybe I'll put that question to Dr. Wirtz. What reflections do you have on that? I take it you're an infectious disease specialist, very much like Dr. El-Sayed in Winnipeg. Like, this process seems crazy to me. Like, if you think it's necessary, surely it should be offered.
Thank you very much for the question, Madam Chair, and I'm happy to respond. Yeah, absolutely. I believe that the process to obtain drugs through the Special Access Program can often be a problematic one. And I don't mean to fault the people working in that program, but the fact is that waiting up to 3 weeks for an antibiotic is absolutely unacceptable when we're talking about conditions like sepsis. Even a few days or a day is harmful or potentially harmful. I've worked for almost 15 years as an infectious disease physician. I work in tuberculosis, and in tuberculosis, we're seeing increasing risks of drug-resistant infections. And the only option in that case, in the case of something called multi-drug resistant tuberculosis, is to use antibiotics that are not available in Canada. So we have 2 out of the 3 antibiotics that are first line for multi-drug resistant tuberculosis are not available in Canada. So it needs to be an application through the Special Access Program. And the program is infuriating, to use the honourable member's words, because we've got a case with a very clear-cut indication with multiple international bodies agreeing what should be the accepted treatment, and yet it takes days or longer to obtain the approval, and sometimes, it's quite variable, the response you will get. Maybe you'll get a response back saying, well, can you justify that a little further? Or, you didn't include, your exact, what you're going to monitor for or what have you. And other times it'll go through. So the process is opaque, it takes too long, and it needs to be streamlined. Thank you for the question.
Thank you for the answer. You're very polite to say you didn't mean to fault anybody in the program, but I think I do mean to fault them. Like it's totally unacceptable, and maybe I won't move a motion now, but I'll maybe put it in the committee's ear that we need to call officials from that program to justify, because I'm an intensivist. I deal with life-threatening emergencies, and it would just make me bananas if Dr. El Sayed was there saying my patient needed a medicine to survive and a bureaucrat was not providing it. Dr. El Sayed, you spoke a little bit about how the AMR program or the antimicrobial stewardship program doesn't twist arms, it's educational. And I guess when I think about the program as being educational, and I had a bout of hemorrhagic enterocolitis this past summer, and the family physician that I saw was using AI to recommend drugs to me. And it seems to me like if AI was integrated in hospital EMRs to say like, oh, I noticed this patient on pneumonia has been on antibiotics for 10 days longer than they need to be, it seems like a lot of that could be automated. What do you think of that? Is there interest in moving towards that?
1 minute.
Thank you for the question. Thank you for the question. Madam Chair, I'm happy to answer it. It's nice to see the honourable member again. Worked with him before, supervised him before. The antimicrobial stewardship programs in Canada, as I mentioned, act in an advisory role, but they do have influence on what types of antimicrobials physicians can prescribe. So there's a restriction policy that we have in place, as I mentioned. In terms of AI, or artificial intelligence, it's been slow to adopt in healthcare, and certainly there's a lot of opportunity to perhaps automate things that might help clinicians. But that's a work in progress. We're actually, just as an aside, we were planning on having an AI certificate pathway for our trainees at Western who are doing infectious diseases, and we had strong endorsement from the division chair for that. So certainly that's something that I think we need to look at seriously. AI is here and it's not going to go away, and we have to find ways to integrate it into healthcare.
Thank you. I think, could you wrap up,
Thank you very much.
Thank you.
Yeah,
Good.
thank you very much.
I'm going to go for 5 minutes, please. Mr. Ailson.
All right. Thank you, Chair. Thank you all for coming. This is very, very useful. Dr. Wurst, particularly good to see you again. We worked in ICU together through the pandemic. Adventurous times, to say the least. So, Dr. Wurst, we were talking about we have these guidelines. How do we transmit these in real time to primary care physicians? Primary care physicians, they take CME, they do their journal reading, but as you well know, it's very, very hard to keep up with everything, particularly in primary care when you're your patients, you also have to know a bit of cardiology. You have to know a bit of respirology, these sorts of things. What would be the solution to getting these, real-time, latest practice guidelines out to primary care providers?
Thank you, Madam Chair, for the question, and also appreciate the question from the honourable member who I know quite well through work through the pandemic that we did. Yes, I appreciate that. The problem of ensuring that antibiotics are used appropriately is multifaceted and really needs to address very strongly those that use those antibiotics the most, and those are the frontline primary care clinicians. And so, there's many strategies that have been used and that are effective. I think the key is not just one thing that is needed. So one important effort is the publication nationally of guidelines for treatment of common conditions, and we have such guidelines, but really we need to bring those guidelines to the clinicians that are working in the front lines, and that's where antimicrobial stewardship programs can really play a key role. It's not just having those guidelines out there in space, because as the member said, these clinicians can be quite busy and not necessarily up to date on the most latest guideline that has come out. So an antimicrobial stewardship program will effectively bring that information to the level of the patient and the provider. So they look at the situation, they would evaluate, is there an opportunity here to apply appropriate antimicrobial stewardship and improve the treatment of this individual patient. So it's patient level. It's not manipulative in any way. It's a guidance that's provided by a program and by experts to better deliver the care that is needed right on the ground level.
Okay, thank you. Thank you for that. Dr. El-Sayed, you talked about this before. You've been asked a couple of questions about it. I've had an interest in this for a while when I first found out that antibiotics are used in animal husbandry. As you said, these are often given in livestock operations, mostly beef, because it promotes growth. The question I have is, how do these farmers access it? Now, if I was to make an outrageous hypothetical, if I was a teacher and decided I wanted to make my students healthier by distributing antibiotics, I could not obtain them because I would need a physician prescription to do that. And no physician would do that, of course. So how are the livestock producers getting these antibiotics? Are there veterinarians that are prescribing them or approving them for purchase by these producers?
Yeah, thank you for the question. Madam Chair, I'm happy to answer the honourable member's question.
1 minute.
During the COVID-19 pandemic, people were hyped up about getting ivermectin as a supposed therapy for COVID-19. And again, there's controversy about whether it actually works or not. But people were accessing it through animal feedlot stores or through non-conventional routes, and they were getting access to these drugs where normally for humans we would have to go through pharmacies or special access programs.
Sorry, I apologize for cutting you off. I'm running out of time. Is there
30 seconds?
Because this really predates COVID. The question I'm going at is that did they not do feed stores sell these antibiotics, or how do these operators get these antibiotics? Do they need a prescription from a veterinarian, or how do they legally obtain them?
Yeah, I don't, and that's what I was kind of alluding to pre-COVID, because now I believe there's still lack of regulation in terms of how farmers can get access to antibiotics. And because I'm not a farmer, I don't know how they are getting access, but I do know that they can get access to these medications far easier than we can in healthcare. And
please wrap up? Thank you. Thanks very much.
And so thank you very much.
All right, I'm going to go to a third round. So I'm going to go to Mr. Bailey for the Conservatives. 5 minutes, please.
Thank you, Madam Chair. Dr. El-Sayed, you just briefly were speaking about medical tourism and the amount of infections that we're seeing coming back to Canada, should we not, as physicians and dentists, telling patients the risks of getting medical tourism?
Thank you very much for the question. Madam Chair, I'm happy to answer the honourable member's question. Certainly, I do try to emphasize the importance of seeking healthcare within Canada. Even some of my family members have asked, I'm going to wait forever to get the surgery. I can get it quicker if I go to this country. And I'll tell them, you know what? Your risk of getting a post-operative infection with a drug-resistant organism is going to be far greater if you go to such and such a country than if you get your healthcare in Canada. Even the United States has a higher incidence of antimicrobial resistance compared to Canada. So I would say Canada is obviously in our healthcare system to encourage more Canadians.
Thank you so much. Dr. Wirtz, necrotizing fasciitis, we've been seeing a very sharp increase in that. And I'm wondering, is this due to initial diagnosis not being proper? Any thoughts on that?
Yeah, thank you for that question. Necrotizing fasciitis, for information, is the most severe form of skin soft tissue infection that we see. And it can be rapidly progressive, has a high mortality rate, and requires urgent surgical intervention to improve outcomes. And as for why it is true that we do see cases coming up. And for example, in my home province, we have a very high rate of incidence rate of necrotizing fasciitis. The reasons underlying that are not entirely clear. This is not necessarily driven by antimicrobial resistance per se, but when we do see infections that are of that nature and severity that are caused by antimicrobial resistant organisms, the results are devastating because we don't have the time to wait days to get the infection under control.
Thank
yes.
you. I'm going to lead up into another question, because with some provinces enabling these safe injection sites, we're seeing so many more needle injection injuries that require IV antibiotics. And I would like your thoughts, because when IV antibiotics aren't effective, sometimes it turns into necrotizing fasciitis. And we're seeing some of the vulnerable population losing limbs. And I heard you speaking about, debridement, amputation are the options. So wondering if it is possible that in the emergency rooms that we're misdiagnosing some of the vulnerable people, or is it sheerly just how aggressive necrotizing fasciitis is?
Thank you so much for the question, and I really appreciate that, because infections related to injection drug sites is one of very near and dear to my heart. I would propose that it's a combination of the factors that the member has brought forward. So we are seeing many infections that are presenting late related to injection drug site infections, and that certainly contributes to the problem. In some cases, I'm sure it has happened that they are vulnerable individuals that have a hard time advocating for their health. So they may have initially been misdiagnosed, and I'm sure that has happened as well. So this is a major, and it continues to be a major problem that requires prevention as well as good and appropriate and timely access to treatments.
Thank you, Doctor. Madam Chair.
45 seconds.
Madam Chair.
Yes.
At this time, I'd like to move the following motion that was put on notice on Friday, November the 28th, so all members should already have it in both official languages. Would you like me to read the motion, Madam Chair?
Yes. Is it pertaining to the agenda, the subject that we're dealing with today?
It
was tabled.
It was tabled.
Yeah.
That the committee invite the Minister of Health and the departmental officials to appear to testify on the supplementary estimates B on December the 4th, 2025, or December the 9th, 2025.
Thank you. If the witnesses will please excuse us while we deal with a motion on the floor. Anyone wishing to speak to the motion or against the motion? Yes, Mr. Major?
Yeah, Chair, I'd just like Guess if we could see CQC, just unanimous consent on this, it's been tabled. We all would like to hear the minister come in next week.
Good. I get unanimous consent from the floor, so we can move on that. That motion has been passed.
Oh, no.
We're not done yet. We're not finished. Oh, I'm sorry. No, I was just saying excuse us while we deal with this. It's kind of difficult when we get motions pop up in the middle of witnesses. I'm sorry about that. I apologize. Thank you. Okay, so that's been dealt with. The motion has been carried. And so I'm going to go to Ms. Jacek for the Liberals.
Thank you so much, Madam Chair. Many of the witnesses today have talked about national surveillance. There are models. It seems like many recommendations have been made to include other sites for surveillance, such as long-term care, community, and so on. And I'm all in favor of data. But the next step is stewardship. And I would like to just dig a little bit into that because we do have some data from 2023 that shows that there was only a 6.6% decrease in annual antimicrobial prescribing compared to 2019. In other words, presumably stewardship efforts are having some impact, but it's not exactly a dramatic decrease. So could perhaps Dr. Wirtz, you could start off with describing what comprises the stewardship program, how you try and avoid the inappropriate use of antibiotics, either the dosage or, in fact, that particular compound. Presumably, education is key in this, but how do you see this rolling out, and how could we make it perhaps more effective compared to the rather small decrease that we've seen today?
Thank you so much, Madam Chair, for the question. And the honourable member is absolutely right that antimicrobial stewardship is a program that is designed to improve antibiotic prescribing, so getting the right drug to the patient at the right dose and duration. And this requires a multifaceted approach. So it's really a quality improvement program. And we have different tools to address that. But probably the most effective one is something we call audit and feedback. And this is where in cases where antimicrobials are being used, especially in those cases in the hospital in this setting where there's really a need to review the antibiotic, the antimicrobial stewardship team, which is a team of pharmacists and physicians, will actually go to the patient, review the case, and apply the most relevant evidence and guidelines to improve the antibiotic prescription. And really, they're offering a recommendation to the treating physician. And so this has a benefit of not only improving the situation for the patient, but also over time changing the culture by really bringing that evidence at the level of patient and prescriber. So that's one tool. It's called audit and feedback. Education plays a huge role, and that is not enough by itself. We need to have the boots on the ground to provide that antimicrobial stewardship.
Do you see those boots on the ground being comprised of the infection control practitioner that is in the hospital? We're talking about the acute care setting in this instance, of course, because in Ontario we had a very strong system of infection control practitioners in each acute care facility. Would they not be vital as part of the team?
Thank you, Madam Chair, for the question. I agree that infection prevention and control are a vital resource, and they are present in hospitals, and they have a very strong overlapping role with an antimicrobial stewardship team. But antimicrobial stewardship teams have a slightly different focus, and it's really to bring the best antibiotic recommendations to the patient, not just prevention and control. Most cases, an antimicrobial stewardship team is run by pharmacy, whereas antimicrobial stewardship IPAC teams are more so led by nurses as well as supported by their physician leaders. Yeah, well, they're all leaders, but yeah, they work together.
1 minute.
in the old days, when I practiced medicine, which is a long time ago, we used to wait for the gram stain, the culture to come back from the lab before we prescribed. Has that gone out the window, so to speak? Patients seem to be requesting antibiotics for whatever ails them. So are we not waiting for at least some lab results?
Not at all. The practice of medicine hasn't changed so drastically since you've practiced, since the honourable member has practiced. It depends. It depends on the severity of infection and how long we can wait to prescribe an antibiotic. So in some cases, we're seeing patients with sepsis or a severe life-threatening infection where we do need to prescribe an empiric antibiotic before we obtain the culture results, which can take, as you say, a day or more than that day. So it really depends. In less dire situations, it's still absolutely recommended to wait for the culture.
I now go on to the next questioner, Madame Larouche. Do we need Demi, s'il vous plaît?
2.5 minutes. Thank you. Thank you, Madam Chair. For this round, Mr. Wirtz, do you share the opinion of the Auditor General, who speaks to the lack of data on vulnerable populations in some geographical zones, and what would be the impact on antimicrobial resistance?
I think that, thank you very much, Madam Chair, for the question. When we speak of vulnerable populations, I think that we do have some further work to do to understand them better and how we can better serve them. The issue is that these populations don't necessarily present early for care. They may be more at risk for infections due to a confluence of factors, including overcrowded housing, shared risk factors such as injection drug use, and lack of appropriate sanitation. So they're increased risk and they present late. And so they see a lot of antibiotics. And we know that from studies looking at populations, they get more antibiotic use and consequently see more antibiotic resistance. So I think this is a key population to focus on when we're thinking about how do we help prevent and treat infections and prevent antimicrobial resistance. Thank you for the question.
Donc, pour servir ces...
So you were talking about the vulnerable populations and also the geographical issue that some populations in a rural setting might be less served. So what would be priority things that we could be done to address this inequality of care?
That's an excellent question, Madam Chair. I think we need to make sure we're bringing the information not only to the physicians but also to the patients, and at a level that everyone is understanding, so that we can actually, inform them and make sure that they're seeking care and that they know the appropriate actions to take when they do become ill.
I now go to Mr. Major for the Conservatives. 5 minutes, please.
Thank you, Chair. I'll cede my time to Mr. Epp.
Thank you, Madam.
5 minutes, please.
Thank you, Madam Chair. The issue of the state of our nests and domestic manufacturing of PPE has been one I've been wrestling with for a while. I know a number of people have been frustrated with the lack of being able to get answers. I appreciate the testimony today. I wasn't able to get to all my questions, and so, Madam Chair, arising from the testimony that we have heard, I would like to move the following motion. And I know the committee has the authority to compel PIAC to appear and other departments, but I wonder if they want to consider just writing a letter so that they have a timely response for the purposes of the study. And so I'll move the following motion, Madam Chair, that the committee order the Public Health Agency of Canada, Health Canada, Department of National Defence, and the Department of Public Services and Procurement to answer the following questions and report back to the committee. And just by the way, I believe the clerk is circulating all of this in both languages. Regarding the National Emergency Stockpile and ESS and the procurement of personal protective equipment PPE from 2019 to the present. Question 1. Which companies were awarded contracts under the 2019-2020 standing offer for the supply of PPE to the NES, and what was the total dollar value of the contracts awarded to each company? Question 2. How many units of PPE were purchased by the federal government for the NES under the 2019-2020 standing offer between March 20 and October 2025, separately identified by year and supplier? Question number 3. How much money in
Mr.
total
Epp,
was spent?
I'm sorry to cut you off, but we do not, everyone does not have this motion in English and French.
It should be in
It's
your
only in
investors.
English, I'm told by the clerk. She does not have it in
Okay,
French.
it is coming in French. It's coming in French. Do you want me to continue or pause until everyone has it in French?
Well, perhaps we could suspend a bit until we get it, so that everyone can look at it before they debate it. Thank you. Suspend. call the meeting to order. Sorry you're not ready. All right. I'm sorry I suspend again. The meeting. Thank you. Meeting is resumed. Yes, Madame Larouche.
Oui, est-ce qu'on, Madame?
Madam Chair, we agree with the questions asked, and when there's one witness, but to not push back the study, I would ask to give 2 weeks. 2 weeks to be able to respond to these questions and to the letter. So I propose an amendment to have answers, and at the end of the amendment to propose to give 2 weeks for the answers to be provided.
Could you please read your amendment, Madame Larouche?
I haven't read the motion yet. Yeah.
Donc, je fais une proposition.
So I'm making a proposal that we give 2 weeks to respond, to not push back the study or delay the study.
Madam Chair, if I may. Okay.
Amendment, Madame Larouche, your amendment just says to push back on the 2 weeks. Is that your amendment? I'm sorry, Mr. Epp. Madame Larouche has the floor.
Report back to the committee within 2 weeks. Is it 2 weeks?
So the following questions and to report to the committee. So here we would add to have a limit in time of between now and 14 days.
Suggesting to report back within 2 weeks.
Mm-hmm.
Yes?
Oui.
Okay, we have an amendment on the floor which will add to report back within 2 weeks. Names for the amendment, please. Any names, Mr. Epp, to the amendment?
I just want to see clarity. Is my motion, because I have not read the whole thing into the record, it has been circulated, has it been considered duly moved?
I think it's been considered duly
Okay,
moved.
duly. If that's been duly moved, yes, I would consider that a friendly amendment.
So, speaking to the amendment, anyone speaking for or against the amendment? No discussion on the amendment. I get a sense, unless you want me to record a vote, that the amendment passes. All right, so we now go to the motion as amended. Any debate, any discussion on the motion as amended? Seeing none, I think the amended motion passes. Okay, that's good. That's great. Now, we have spent 22 minutes suspended. We began the meeting 4 minutes late. So I think that perhaps now that we have one more person to speak, and that would be Ms. Sidhu. We'll give Ms. Sidhu the opportunity to ask her questions. Thank you, Ms. Sidhu.
Thank you, Madam Chair. Thank you again, all the witnesses. My question is that the question, I think, Dr. Wirz, you can, more use of antibiotic is agriculture sector. Anyone can give me other doctor from the Western, Dr. Samir Al-Said, and then I want to listen from both how we can regulate that agriculture industry.
Yeah, thank you, Madam Chair, for the question. I'll note that my area of expertise is in human health and not in animal health. However, it is true that the problem of antimicrobial resistance is a multifaceted one. It involves primarily, if we want to address the issue effectively, addressing antibiotic use in humans, but we also need to address it in the use in animals and also in the environment as well. So these are the three pillars that Canada's AMR action plan from 2023 mentions and addresses. And the issue I'll mention again is that there's a lack of, not a lack of a plan, but a lack of implementation timelines and indicators, okay?
With that, I just want to raise another point. Infection prevention is one of the strongest tools we have to reduce AMR. So I know we talk about if it's needles. Talk about the needles. If there's injection sites, harm injection sites, or where there's control of the drug and needles, so it also decreases the infectious. Are you agree with that, Dr. Wirtz?
Thank you very much for the question. The question is whether safe injection sites may reduce the risk of drug injection infections, and the answer to my answer to that question is yes, I think so. The issue is that many times injections occur in very unsanitary conditions, sometimes with reused equipment, and any effort that can be put towards harm reduction in reducing these types of infections and preventing them in the first place is going to be an effective one for reducing morbidity and mortality related to those vulnerable individuals that we spoke about earlier. So thank you very much for that question.
Thank you. And what type of federal public awareness efforts would most effectively support infection prevention?
So thanks again for the question. I believe that the issue that we have is not one of the issue is that we need more implementation across the country, and for that, I would turn to the federal government to basically create standards that need to be applied across jurisdictions to ensure that we don't see major differences in antimicrobial programs and antimicrobial use from province to province. Federal government plays an important role in providing those standards and also ensuring that they're upheld. Thank you very much.
My next question is to Dr. Thami. Dr. Thami, you talked about that Pan-Canadian Action Plan. How can better integration between pharmacy systems and prescribers and surveillance programs improve stewardship and patient safety?
Yeah, thank you. Thank you for the question. So one of the opportunities that we have is to better integrate some of our health information systems. Now, within a hospital setting, all healthcare practitioners are going to have visibility to the patient's lab values, the patient's medication record. They'll have access to notes from physicians or other healthcare professionals that are taking care of the patient. You can see the fulsome healthcare plan. However, where that breaks down is once the patient sort of leaves the four walls of a hospital. So again, when we talk about long-term care, when we talk about primary care, there's certainly, again, that opportunity to improve that information sharing and communication between the prescribers and the pharmacists. As well as sort of integrate better opportunities
20 seconds.
for handing over the care plan for the patient. Oftentimes, pharmacists in the community are ones that have ongoing contact with patients and can help monitor for adverse reactions and help monitor for opportunities where they need to go back and see a physician to get either alternate therapy or lengthened therapy.
Thank you, Ms. Sidhu. Now, I would like to thank the witnesses very much for taking the time.
Point of order.
I'm sorry you had to wait
order.
for so long. Yes, Mr. Major.
I was just wondering if we have a few minutes left. I didn't know if, since it's Block's study, if we just give her 2.5 more minutes, another round?
Well, this
we
is a
have-
round in which
Yeah,
Ms.
I just-
LaRouche
just
had
as-
2.5 minutes already in this round.
Yeah, but just to extend it on, if the committee's in agreement with it, if...
Well, let's
She
wait
missed her-
until I will ask the committee if they're in agreement.
Yeah.
Is the committee in agreement to give Madame LaRouche another 2.5 minutes? Thank you. Madame LaRouche, 2.5 minutes.
Beaucoup, Madame la Présidente.
Madam Chair, this study reminds me of the volunteer work that I did for an organization that was doing a prevention of nosocomial infections. And we had an event, Wash Your Hands, and we made people realize the extent to which it's important to respect some standards, to wash one's hands properly to prevent disease. And even there was a lot of awareness. We did this even in hospitals. And so it reminds me the extent to which this is important. So my next question might be for Dr. Stinson. What are the most important obstacles for prevention strategies in different settings, hospitals, CHSLDs, clinics?
Oui, merci pour la question. Donc, je vais
Thank you for your question. I'll answer in English.
So in terms of overall barriers, I mean, you're certainly right. Hand hygiene is probably one of the most consistently significant methods of preventing transmission of infectious disease and antimicrobial resistant organisms in all health settings. One of the barriers that we often see to implementing that is overall resources. And so when you think of, and I believe it was Dr. El-Sayed had alluded to the challenges we see in healthcare right now of over census, too many patients, resource limitations. When you compound all of those factors together, it's easy to start saying, well, I can just take a shortcut here. I could take a shortcut here. I don't need to wash my hands. I don't need to worry about my PPE. We could translate that to antimicrobial stewardship. I can just kind of cut out and simplify my antimicrobial ordering practices for simplicity's sake. And ultimately what it comes down to is overall resources of our entirety of our healthcare system, not just in personnel, not just in physical infrastructure, but everything.
Il me reste 15 secondes, donc
15
rapidement.
seconds, so quickly. For resources, the importance of healthcare transfers to give more financial means. I asked my question. So the importance of increasing healthcare transfers to have more resources.
So I will now adjourn the meeting, it being well after 1 o'clock.